Good evening. Welcome to another episode of Fresh Natural Live. We are live, fresh and natural. Here on a Monday evening, it's October 3rd, 2022, and we're going to be talking about atrial fibrillation. I was watching a little bit of football this weekend, and I found out that a former star of the Houston Texans, J.J. Watt, was diagnosed with atrial fibrillation. And I started thinking about that, and I said, well, a number of athletes in the past have been diagnosed with this arrhythmia. We commonly see it in older adults with chronic heart disease, but it can be seen in athletes. And we're going to talk about that in a little bit of detail. I'm going to talk to you about atrial fibrillation and give you some insight. It's the most common arrhythmia that we see in cardiology, and I think you should know a little bit about it. So stay tuned. This is going to be a great show tonight. Okay, so you caught me here looking at my screen. Welcome back. We're going to be talking about atrial fibrillation today. And as I said, I was watching football this Sunday, and the defensive lineman, J.J. Watt with the Arizona Cardinals, it was reported that he was diagnosed with atrial fibrillation. Apparently, this information was leaked, but the part of the story I know is that he had been feeling bad at practice one day. He was feeling weak and tired and underwent an evaluation, and apparently an EKG was done. He was found to be in atrial fibrillation. He was taken to a hospital seen by cardiologists and underwent treatment for the atrial fibrillation. And I want to talk about what that treatment was, at least the reported treatment. But before I do that, I want to talk about atrial fibrillation. Atrial fibrillation is a very common arrhythmia. As an electrophysiologist, I've dealt with hundreds, thousands of patients with atrial fibrillation. I see it a lot in my patients today. And it's an arrhythmia that we have to manage very carefully. So I'm going to get started on that. Let's talk about atrial fibrillation. We're also going to look at one particular procedure that's used to treat atrial fibrillation called cardioversion. But before we get on to this, I want you to give us the thumbs up, show us some love. If you hadn't had a chance to subscribe to this channel, please do so and share it. So thumbs up, subscribe, and share. Hello, everyone. Hello, Bernadette. Okay. Hey, Dr. M, we were just discussing you in 10 million Black vegan women group breakout. Okay, wonderful. I'd like to hear what that's about. William Bespoke Bibbs. So welcome to the show, guys. Let's talk about atrial fibrillation. I have a few slides I'm going to share with you. Atrial fibrillation, as this slide implies, often can require the use of lots of medical therapy. And here's a nice schematic that shows an EKG tracing. Now, many of you who don't know what EKG tracings look like, I'm going to walk you through this. Above, you can see here's a normal tracing, and below here's a tracing with atrial fibrillation. If you look here, this little letter with an arrow is called a P. We call this the P wave. And the names are not that important. This little bump, you see a bump, and you see a spike, and you see a hump. Bump, spike, hump, bump, spike, hump. The bump, spike, and hump, that cluster of three things represents an electrical cycle for one heartbeat. So the bump is the electrical signal that comes from that passes through the upper chamber. The heart has four chambers. It has two upper and two lower. The upper chambers are called atria. The lower chambers are called ventricles. The upper chambers, which are atria, you have the right atrium and the left atrium. These are chambers with fairly thin walls, so have a thin amount of muscle in it. So when electrical tissue passes through the thin electrical muscle of the upper chamber, it doesn't give us much of a signal. So you see a smaller bump. But then when the electrical wavefront passes through the lower chambers, the lower right and left ventricles, they're much larger chambers with thicker muscle walls. And so they give a larger electrical signal. So you see a larger spike here. And this hump represents what we call repolarization. When an electrical signal passes through tissue, the tissue, which starts off polarized in one direction, is polarized in the other direction. And it has to flip back and be polarized in the original direction in order for the electrical current to pass back through. And this polarization is based on cell by cell. What we're looking at here is the summation of electrical signals and the summation of polarization and repolarization that passes through all of the heart muscle tissue. Now, the repolarization of P wave is buried here in this activation. So that's why you don't see a small little hump representing repolarization of upper chambers, but this is repolarization of lower chamber. So electrical signal passes through the upper chamber, a bump, lower chamber, spike, hump, bump, spike, hump, and so on and so forth. So that's a normal rhythm for normal electrical signal, etc. However, something can go wrong in the heart muscle tissue, particularly in the upper chambers, where you go into what's called atrial fibrillation. And so that's what we see here. Notice instead of this small bump, you see these little things here. See this little erratic squiggles. They're not the squiggles. That's atrial fibrillation. And notice how the spikes, this is the electrical activity in the lower chamber, how they're organized and they're farther apart. Because when the electrical signal goes through the normal conduction pathways, conduction to the lower chamber is normal. When it goes through abnormal pathways, or there's an abnormal circuitry that's controlling the electrical signals in the upper chamber, then the conduction to the lower chamber is more erratic. And the conduction passing through from the upper to lower, through the conduction tissue from the upper to lower chamber is much faster, and it bombards the lower chamber so that the lower chamber beats faster. So that's why these spikes are much closer together. So this down here is beating anywhere from 3 to 4 times faster than the heartbeat up here. So you see you have a atrial fibrillation is faster heartbeat and more erratic. So if any of you have had atrial fibrillation and you feel your heart palpitating, it may be palpitating irregularly, and therefore you're getting a rapid, irregular, and erratic heartbeat, and that's typical of atrial fibrillation. Now, I'm not going to bore you with too much what we call pathophysiology, but I think it's worth getting into a little bit of this, because if you look at this is a CT scan of the back of the left atrium, which is an area that we put a lot of attention to when we're dealing with atrial fibrillation. And the left atrium can have these areas of rapid focal signals. And you can get a lot of these rapid signals. And I say rapid focal signals, these are excited tissue. And so you may have two where you have multifocal atrial tachycardia. You may have 3 or 4, but you can have infinitely many erratic sites. And these infinitely many erratic sites are sending little signals from different locations. And they're usually like reentry circuits that are coming from different locations that's causing this erratic and irregular, rapid, erratic and irregular conduction from the upper chamber to the lower chamber. So that's what we're dealing with, is sort of electrical chaos in the upper chamber. So the upper chamber goes from beating normally and synchronized to beating erratically. And so that's what we're dealing with here. Uh, so here's another schematic, sinus rhythm. It's a little more of a cartoon, but it shows the erratic nature that converts this person is clutching their chest. Frequently, when you go into atrial fibrillation, the symptoms you feel is fatigue, chest pain, sometimes dizziness. And the reason for that is that your circulation is compromised. Usually, the upper chambers, when they contract, they eject blood from the upper chamber to the lower chamber, and the lower chambers eject blood out. In the case of the right ventricle, the tract ejects it out to the lungs where you get oxygen, and the left chamber the lower ventricle on the left ejects out to the systemic circulation where the body gets oxygen and nourishment. But if the circulation, the contribution of circulation from the upper chambers is taken away, in young, healthy people, that can be anywhere from 25 to 30%, maybe 40%. And the older people can be 50, 60, 70% of their total circulation contribution. So, although younger people can be very symptomatic, feel fatigue, etc., older people can go into heart failure, can be totally wiped out, can have, chest discomfort, fatigue, dizziness. And so they can have severe symptoms with atrial fibrillation, and we have to get them out of atrial fibrillation pretty rapidly. So it can cause symptoms. The other thing is that it predisposes to blood clots. And this diagram is showing a schematic of a blood clot, because when the upper chambers are beating erratically, then blood sloshes around, and because it's not flowing in a hemodynamic or fluid dynamic way, it can get become stagnated inside certain corners of the upper chamber called the atrial appendage. And that's where we look to find clots. And oftentimes you'll find clots in the left atrial appendage. That's a little pocket inside the atrium where we can find clots. And these clots can break off and go to different parts of the body. Sometimes it can cause strokes and cause heart attacks and other other problems. So how do we treat atrial fibrillation? Well, we try to get them out of atrial fibrillation, and we'll talk about that in a minute. If we're not able to get them out of atrial fibrillation, at the very least, we want to control the heart rate. I showed you not only is the heart beating erratically, but it's beating rapidly. So if we can't immediately convert the rhythm from atrial fibrillation to a normal rhythm, we'll at least try to give medication to slow the heart down. And then some of the long-term management includes preventing stroke. And so frequently someone with atrial fibrillation will be started on a blood thinner, and quote unquote blood thinner. They're really anticoagulants. Typically, historically, warfarin was the Coumadin, as people know it as. It was an anticoagulant, but there's some other agents that are used as anticoagulants commonly now. And you don't have to get the frequent blood draws to check your international anticoagulation ratio. But how do we determine who needs a blood thinner or not? Well, it depends on whether you have other illnesses. So, for instance, if you're a young, healthy person, you don't have high blood pressure, and you're physically fit, you don't have congestive heart failure, you never had a stroke before, you don't have vascular disease, et cetera, then you may have what we call a low CHA2DS2-VASc score. There's a scoring system we have where we give you points. And if you see here, if someone has congestive heart failure, they get 1 point. If hypertension, they have another point. If they're 75 years older, they have 2 points. If they have diabetes, they have 1 point. If they've had a stroke or TIA, a thromboembolism of any kind, or a blood clot, if you will, they get 2 points. If they have a history of vascular disease, so ischemia in the heart or peripheral vascular disease, they get a point. If they're age 65 to 74, they get a point. And if they're female gender, they get a point. So you can add these points up in the sense that, let's say you are an 80-year-old female with hypertension. If you're 80 years old, that's 2 points. Female gender is 1 point. That's 3 plus hypertension. That gives you 4 points on the CHA2DS2-VASc score. And looking at this scale, you consider anticoagulation. Really, in this situation, some people say consider anticoagulation. That's a CHA2DS2-VASc score 0. So anybody with atrial fibrillation, you consider anticoagulation. But typically, we don't treat, or at least I don't treat someone with chronic anticoagulation if they have a 0 CHA2DS2-VASc score. If they're on any of these risk factors, I tend not to treat them. And I think most of my colleagues are the same. Now, there may be some other considerations that may bring you into that. These are probably extenuating circumstances. When you get to CHA2DS2-VASc score 2, I consider that borderline. It depends on the patient, depends on what they're doing lifestyle-wise. If I can reverse some of these conditions with lifestyles, for instance, if you're 75 or older, you have a 2, then heck, I mean, that's already a 2. So, you can't reverse the age. With female gender who's 65 to 74, that's 2. So there's some things cannot be reversed. However, what if this person had hypertension, heart failure, and diabetes, and we have a nutritional detox diet, and they're following that, and they're exercising and doing extremely well, and maybe they've undergone a procedure for AFib ablation or not, but we do extensive monitoring. You don't see any AFib after you've done this aggressive lifestyle monitoring program and they stick with it, then we'll have a conversation. If it's their desire to come off anticoagulant, I'll strongly consider it. As the number gets higher, it becomes more difficult. But then as the number gets higher, you have more of these components that are potentially reversible. So someone may start off with a CHA2DS2-VASc score of 4, but if they do things to reverse diabetes, reverse the hypertension, lifestyle wise, and bring yourself down to 2, 2.5, or whatever, then we may consider taking that person off anticoagulation. Again, it's all done on an individual basis, in my perspective, and it's just a matter of seeing what the person's able and willing to do. Here's a slide that talks about the variation. So here you have atrial fibrillation with a fast heart rate. We call it rapid ventricular response. So you may hear people in the medical field, AFib and RVR. RVR is a rapid ventricular response. And so you have AFib there, and then you have rate control AFib. So you may give them a medication like a beta blocker or a certain type of calcium channel blockers that control the conduction of the electrical signals from the upper to the lower chamber. So then there's still an atrial fibrillation, in which case they're still at risk for a stroke. However, you control the heart rate. Now, a fast heart rate can put you into heart failure. So can heart and atrial fib with a normal control rate. However, the faster heart rate has a greater propensity to contributing to the production of heart failure. So you want to control the rate at the very least. And then ultimately, you want to get them into sinus rhythm and keep them in sinus rhythm. The considerations and management is outlined here. For rate control is beta blockers, rapamyl, digoxin, AV junction ablation. When I was an EP fellow, we were doing some of these AV junction ablation. We put a catheter in an electrical area between the upper and the lower chamber, very near the bundle of His. We'll put a burn there, and we'll prevent the conduction from the upper lower chamber and plant a pacemaker. And that was the ultimate way of controlling the rate, because the patient either did not tolerate the medications or the medication were not effective at controlling the rate. So we would do this ablation. Digoxin, rapamyl, digoxin, beta blockers are also useful. Stroke prevention, anticoagulation, as I mentioned. Now, there are new therapies where you can occlude the atrial appendage. Remember, I said the blood clots can form in the little pockets of the upper chamber called the appendage. And so in these little pockets is where you have the greatest propensity for clot formation and therefore stroke. And so several studies have shown using different occlusion devices to close off this little pocket to prevent the clot from being dislodged have been found to be helpful. And therefore, these patients have benefited from that and have been able to come off anticoagulation. At least some studies have shown them to be as beneficial in preventing stroke. There's also a surgical procedure, a minor surgical procedure where you can clip the atrial appendage, just get rid of it altogether. And that also has been shown to be helpful in reducing stroke. And so there is an alternative to anticoagulation as well. Treatment of risk factors. Now, really, the literature has shown the most effective, benefit for AFib is diet and exercise. So you want to treat the risk factors aggressively with lifestyle. Control the high blood pressure, hyperlipidemia. All these things in this list here can be effectively treated with aggressive lifestyle measures. So you can really wipe out this list and really change your overall prognosis with just aggressive lifestyle therapy. And so that's one thing that I encourage people to do from the standpoint of controlling the AFib is to have aggressive lifestyle therapy. Then long-term strategy, reducing symptoms, maintain sinus rhythm, antiarrhythmic medication. There's also catheter ablation. There's also a surgical maze procedure. I don't see many patients undergoing this procedure very much. I remember as a cardiology fellow before they came up with before we were doing AFib ablations with a catheter, there's a surgeon that would do this procedure. He would open up the chest and take the atrium out and put these scars in the heart and put the atrium back together. And that'd be the maze procedure to keep the person out of sinus rhythm. I think there was a fairly high incidence of needing pacemakers after this procedure. But more patients are getting catheter ablations. About 20 plus years ago, I was doing catheter ablations for AFib, and I'll share a little bit about how we do that in just a minute. Well, actually, this is my last slide. So let me just kind of use this other diagram. Here you see, and this is what we call a 3D map of the atrium. You're looking from the posterior side of the heart, and actually, yeah, you're looking posteriorly, but you have the left superior pulmonary vein, left inferior pulmonary vein, right superior pulmonary vein, and right inferior pulmonary vein. So this is a posterior view. And essentially, you see the opening here. This is where the left pulmonary vein opens into the left atrium and the right into here, and so on. When I was doing them, I would put a basket catheter here, and I would find the neck, the ostium of this vein, and I would find the actual electrical signals and burn those individual signals. I would isolate by burning those signals. I do the same thing here, and I go over here and over there. They do it a little bit differently now. They will put a wide circumferential burn. This person isolated both of these veins in totality, and so you have a wide burn isolation here. And that's found to be effective. Now they'll put some burns in the atrium as well. And what that does, that prevents the electrical signals coming from the pulmonary veins into the left atrium. The problem is that atrial fibrillation is not an isolated electrical abnormality. Of all my patients, I ablated with what we call supraventricular tachycardia with a mechanism of avian entrant tachycardia. Had 100% success rate. You go on, there's one pathway, you're going to ablate that pathway, it's done. Wolf Parkinson White, similarly, you ablate that pathway, it's done. Atrial flutter, the typical atrial flutter, in the vast majority of cases, you ablate that critical pathway, and you're done with atrial flutter. With atrial fibrillation, is a little bit different because a lot of atrial fibrillation is not just due to increased excitation from these veins, but it's just due to the fact that because of increased inflammation and increased oxidative stress, you get scarring and you get destruction of the electrical properties of the atrium. And so there's a wear and tear of the atrium. And because there's wear and tear, the electrical signals doesn't transfer normally. And you get disruption of electrical signal, and then that sets you up for atrial arrhythmias. And so you can do the ablations, but most people require 2 ablations. And even after 2 ablations, many people require medications. And if they don't have aggressive lifestyle changes, you have a significant failure even after 2 ablations and medications. And so essentially, there's a high recurrence rate, large, not because the ablation procedures are not good, it's just because the overall cause of atrial fibrillation is more of a systemic insult on the heart myocardium, particularly the atrium. So here's a diagram showing this procedure, and I used to scrub up, and you place these catheters, have a CT scan mapping, have these complex electrical signals that you're observing, and you're manipulating your catheter and mapping and putting your burns into the left atrium. A fairly complex procedure, but it's commonly done, and it can be done fairly effectively and safely. So what I've done is given you an overview of atrial fibrillation, and the key story was an athlete, J.J. Watt, who had atrial fibrillation. And many of you may say, well, why would an athlete have atrial fibrillation? These are young, healthy individuals. Actually, there are many athletes, well, I say many, a number of athletes over the years have been diagnosed with atrial fibrillation. Some required cardioversion, some required ablation therapy. And so athletes are humans too. They seem like they're superhuman, but they're human. And as I said, atrial fibrillation is a systemic disorder. And so if you look at, okay, why does someone go into atrial fibrillation? Well, increased inflammation, increased oxidative stress. Well, what causes inflammation, oxidative stress? Well, exercise can do that. But your diet, I mean, the foods you consume, if you're consuming processed sugars and processed carbohydrates, you're consuming excess animal protein that triggers inflammation, you're consuming, saturated fats. All of these things contribute to increased inflammation, oxidative stress. And just like they can cause any other disease, they can cause atrial fibrillation. So even though you're a young, healthy athlete and you exercise, and those are all positive things, if you're consuming the standard American diet, we know that many athletes who've consumed the standard American diet who've had problems. And so atrial fibrillation isn't significantly different in that regard. So J.J. Watt, as I said, was feeling symptoms of fatigue during practice, wiped out. And J.J. Watt, from what I recall, when he was a Texan, was always in shape. Always worked out, kept himself in tip-top shape. He wasn't the type of individual who, as best I can tell, slacked off from working out and coming to training camp in shape. Very dedicated to his field. So he felt fatigue and was then diagnosed with atrial fibrillation. So the question is, why did he feel fatigue? As I said before, the upper chambers of atria contribute to your cardiac output. It contributes to your circulation. So if his atria goes from beating like this and all of a sudden start fibrillating, then that compromises the flow of blood within the heart and therefore the flow of blood from the heart. So you can imagine someone with increased demand of cardiac output. He's running, he's jumping, he's going against offensive linemen. They're doing lots of agility drills in practice. So he needs a very high cardiac output. It's very demanding sport. So if he has 10%, 15%, 25% drop in cardiac output, he's going to notice that. And so that's essentially what I think happened. And as a result, he was evaluated and fortunately found the cause and underwent a cardioversion. So